Yes, and here is your question. Yes. Timer started. Yes, please.
Should I answer, ma'am?
Just a second, few seconds.
Hello.
Yes, now. So if you have read and understood, considering a surgical pathology patient, kindly tell me what are the differential diagnoses that you will consider for this patient?
This is an old patient, comes with pain during brushing her hair and chewing the food.
Straight, yes.
transit
Tell me
loss of
straight to the
vision.
differential diagnosis, not why.
And it may be the giant cell arteritis or temporal arteritis.
Anything else? Any other condition you will consider?
Maybe this patient will come with a stroke.
Do you think she has stroke? All right, what is giant cell arthritis?
Ma'am, giant cell arteritis is an inflammatory disease of the large and medium sized vessels of the head, mainly external branches of external carotid artery.
All right, can you please tell me, if you'll do the lab for this patient, what are the investigations that you'll ask for to confirm your diagnosis?
Okay, at first I will do a complete blood count to see there is any infections like WBC.
Yes.
Then I will see the ESR, and which will be elevated in that case. And if it is chronic, so to diagnosis it, I will do the C-reactive protein. And we to exclude is any kind of bone disease, I will do procalcitonin.
Okay, what is the role of platelets in this condition, or asking for platelets count?
Yes,
How
I will ask
how would
for
that be affected?
platelet count, ma'am.
Yes, why? How would that be affected, or what's the significance of asking for this test?
Yes.
Okay, any other test which is of most important significance for the diagnosis of this patient?
Okay, as this patient has the involvement of the artery, so we will do some confirmatory tests like temporal artery biopsy.
Biopsies, yes.
Before
That
biopsy, I will do. Yes, ma'am.
Yes, that is the most important one. Okay, can you please tell me which part of the vessel most commonly is affected?
Usually, ma'am, the tunica media part of the blood vessels.
Okay, can you describe the pathological changes that occur in microscope?
Okay.
Under microscope, if you can look at it.
As it is the involvement of the arterial segment, so there is narrowing of the vessel due to intimal thickening, and there is accumulation of granulomatous inflammation on the internal elastic lamina, so causes fragmentation, and there is infiltration of the T cells and the macrophages.
Yes.
So which form the multinuclear giant cells, and there is focally distributed along the vessels and long segments.
What are the risk factors which you have to consider for giant cell arthritis?
The risk factors like, ma'am, the patient who are old age patient.
Yes. And female gender.
And the patient and female.
Yes.
Old age female who are taking steroid therapy, steroid for a long time.
Those are the causes for risk factors for osteoporosis. Okay, what can you tell me? How would you manage this patient? What is the treatment options considering its joint
Okay.
cell arthritis?
As the patient will present with early stage, we will give him oral prednisolone at 60 milligram per day. If the patient will come with a blindness or loss of visions, then we will immediately start with him injectable methylprednisolone with a 2 years course.
Okay, can you mention the consequences of taking long-term taking steroids?
Long-term taking steroids has involvement in the multi-system, like it will involve it can present with the Cushing syndrome, and the patient will present with the osteoporosis. In case of GIT involvement, there will be gastric ulceration, there is weakening of the bones, and patients will become immunocompromised.
Yes.
And
Good.
thus the patient will present with us.
All right, good. Can you please tell me if you'll do the biopsy of this condition, what are the features that you'll appreciate on biopsy report?
Biopsy report, ma'am. Mm, um, can't remember, ma'am.
Okay. Can you tell me why would this?
Okay, ma'am.
patient-
Yes, ma'am. Biopsy will present with some luminal stenosis and
Intimal
with
thickening.
infiltration of
Intimal thickening with luminal
infil-
stenosis. And
yes, intimal thickening. There are some infiltration of the inflammatory cells in the tunica media.
yes,
And
mononuclear
necrosis.
cells. Yes.
And some giant cell
All right.
formation. Yes, ma'am.
Right. This patient may present with visual disturbance. Why?
Yes. Because there is the occlusion of the ophthalmic artery, which mainly feeds the eye directly. So the patient will come us with the loss of vision.
Yes, because of ischemia. Okay. Right. Can you please tell me that, or you already told me the risk factors or the causes? Okay. What is osteoporosis? If I ask you to define it.
Ma'am, osteoporosis is a condition where there is the reduction in the bone marrow density with deterioration of both micro features, like bone become more fragile and fracture.
All right. Can you mention few side effects of steroids? Are they same as the risk factors?
Like the patient, in case of old age patient, patient will present with us
Can you
the
tell me what is pathological fracture? Yes.
Pathological fracture.
What are pathological
Yes,
fractures?
pathological fracture.
Can you define?
Fracture which occurs in the abnormal or diseased bone.
Yes.
Without any or little trauma.
All right. Okay. How should that fracture be managed?
Usually this kind of fractures will manage with like some lifestyle modifications, like stop smoking, then hormone replacement therapy, like, and the bisphosphonate give the patients to increase the bone marrow density, and along with the calcitonin, and low dose steroid should be prescribed.
Okay. Right. Right. You said management for this condition can be that you give steroid to the patient. All right. If patient presents with pathological fracture and your patient has to undergo surgery, why is it important to keep in your mind that patient has been taking steroid?
Ma'am, because there is a chance of, as there is pathological fracture, there is a chance of occurs of fat embolisms. So that's why we have to take some
You haven't, no, you, I'll repeat my question. Patient has been
Yes, ma'am.
taking steroid. Now
Yes,
patient
ma'am.
has presented with pathological fracture and you have planned to do, to operate on the patient, right? So
Yes, ma'am.
why is it important to keep in your mind that patient has been taking steroids?
Okay, ma'am. There is a chance of occurs of Addisonian crisis.
Yes.
So
So
to
what should you do? Yes, please. For
to
minor
avoid
surgery and
the
for major surgery, how would you manage?
okay, for minor surgery, we will stop the steroid. Um, like we will give low dose steroid orally. But in case of major surgery, we should have to give 200 milligram IV for 24 hours. And after this, if it is needed paraoperatively, we have to double the dose. And in case of minor surgery, we will continue the steroid for 2 to 3 days. But in case of major surgery, we have to continue it for 7 days. Hello?
Yes.
Yes,
7,
ma'am.
I can't. Every 8 hours for 48 to 72 hours. That's what I have. For 7 days, IV. No.
In case of major surgery, we will give steroid for 7 days or minor for 2 to 3 days.
For
And
moderate
preoperatively, we
one.
will give 100 milligram IV hydrocortisone or 200 milligram for 24 hours. And if needed, we will double the dose, ma'am.
Okay. Right. Started the timer. Who's sending what? Okay. And here is your question.
Yeah, I've read it, ma.
Yes, just few seconds left, please. Right. So if you have read and understood, considering it's surgical pathology patient, kindly tell me what would be your answer to this patient and what is the pathogenesis of this condition?
Okay. The answer is she had a complicated diverticulitis. I think she developed a fistula and subsequently had peritonitis from the complicated diverticulitis.
Okay.
The diverticulitis usually occurs in patients with diverticulosis from inflammation of the diverticulosis, which then proceeds with increase in intraluminal pressure, and subsequently they can perforate, and it's usually common in the sigmoid colon. So
Okay, which layer of which layer it weakens?
yeah, it's usually the areas that are not reinforced by the longitudinal muscles.
Yes.
Yes. So where
Wall
the
of
vasa
tinea
recta.
coli. Yes, tinea
Yeah.
coli. All right.
So
Can you tell me how diverticulitis takes place, if you can classify?
okay, it can be classified as acquired and
Congenital. Very good.
diverticulitis and congenital. Yes, acquired and congenital.
All right. Can you please tell
diverticulosis.
me, if you don't manage that right now, what are the complications that you can expect?
Okay. The complications that could occur include there could be inflammation, then an abscess could also occur. Then patient could also have peritonitis from fistulation of the diverticulitis. And also there is also history of malignant transformation. Then patient could also have intractable pain, which could be from bleeding and also from adhesions from the
ultimately
diverticulitis.
leading to intestinal obstruction.
Yes, it could also
All right.
cause.
Can you please explain me how did the endometriosis got to the colon? How
Okay,
did it reach? Yes.
there are theories that have been implicated. The
Yes.
first theory is retrograde menstruation.
Yes.
Then also there's a theory of the progenitor cells from the bone marrow that
Yes.
just produces cells that are endometrial cells. Then also the common embryological origin of some cells from the coelom, that's the mesonephric origin. So some of these cells will undergo some form of metaplasia and they could develop endometriosis. Then there's also there's also a theory of benign metastasis.
Yes.
Being a benign disease, it could just seed and be transferred to distant sites that could also occur.
There is another theory which is named as extrauterine stem or progenitor cell theory. Can you tell me about that, please?
Yeah, the extrauterine progenitor is, I think, is the one from the bone marrow cell, from the bone marrow, man. I'm not sure. I'm not too sure, man. I can't remember.
Yes, from the bone marrow, but it differentiates into endometrial tissue. Okay, why do you think this patient developed a collection in the left iliac fossa and why it caused pain?
Yeah, the collection could be from abscess formation, and it could also be from bleeding, intra-abdominal bleeding, and also subsequently with adhesions that would ensue. The patient can develop abdominal pain.
Okay, can you please tell
And the
me?
mass
There is one classification system according to which you can classify diverticulum in particular. Can you please tell me?
Yes, is the Hench
Yes,
classification, which
one.
classifies that the one is pericolic abscess.
Yes.
2A is a pelvic abscess.
Yes.
2B is a complicated abscess that has a fistula. Then 3 is purulent peritonitis, and 4 is fecal peritonitis.
Okay, good. What should be the management that you can offer to the patient? Management that you can offer?
Yes, management of the patient should be I'll go about it by the care of the critically ill patient. So this patient to be managed by adequate resuscitation, which entails use of IV fluids, IV antibiotics, and also patient in pain will also be given analgesics, and also series of investigations to monitor the patient's, for example, the fluid intake and all, to ensure adequate resuscitation will be done.
Good.
Then having resuscitated the patient, then they can be managed surgically, operatively.
Right. If you, since patient had peritonitis and you had to operate on it, so you looked inside the peritoneum, what kind of picture can you tell me? What kind of intraperitoneal picture did you see? Considering it's endometriosis and diverticulitis.
Okay, it will be that's macroscopic or microscopic, ma?
Macroscopic.
Micro.
Macro. With the naked eye, you looked.
Okay. There will be exudates. There could be exudates around
what
the
color?
Exudates.
Chocolate
yellowish,
brown powder, dark blue, black, this sort of. All right. Can you please help me?
Brown, black. Yes, brown, blue, black.
Yes, please. Can you look at these two slides side by side and please tell me or explain it to me or describe it to me, please? What are you looking at? Which stain has been used for the preparation of these slides? And if you can explain, what are these that you're looking at? why there is so much color difference, and what are these that you are looking at, please?
Yeah, I can see area of patchy necrosis. I'm not sure, and I'm not too sure, ma.
Okay,
I will
we'll
pass, ma.
revise that. Okay, all right. Can you please
Yes.
tell me what relation endometriosis has with the transformation or conversion into malignancy? Does it have any or not?
Yes. Yes, it does. Usually in the ovary, about 3 folds.
Yes.
Yep.
Threefold. Okay.
Patients with endometriosis have 3 folds likely to have malignancy in the ovarian.
Okay. So in that condition, when patient has already known the endometriosis, what would be the epithelium of uterus?
It's simple and simple columnar with a rich stroma.
Okay. Right. So
Yes,
can you please tell me, or Bella is gone, but can you please tell me what antibiotics would you think of giving to this patient, if any?
yeah, I would want to give amoxicillin for the gram positive, gentamicin for gram negative, clindamycin for anaerobes, or metronidazole. But I'll
Okay.
go with clindamycin first for anaerobes.
All right. Can you please tell me how the neutrophils, they migrate in this condition to the site of infection?
Okay. Usually the neutrophils, firstly, they will roll.
Yes.
After the rolling, they get ahead by
Yes.
by the use of integrins. Then they also migrate through they'll migrate then subsequently, which is aided by the ICAM, ICAM1, ICAM2. And by the aid of the chemoattractants, they migrate to the final destination.
All right, good, thank you. And here is your question. Right, so if you have read and understood, considering its surgical pathology station, what are the differentials you'll consider for this patient?
My differential diagnosis includes a right undescended testis. It could be a right testicular tumor located in the groin, in the right groin. It could be a right inguinal hernia.
Yes.
It could be a right groin lymph node. It could be a Malgain's bulge.
Very good, very good. All right. Can you please tell me what are the most common locations for undescended testes?
Undescended testis usually located along the line of descent of the testis. It's commonly located in the groin, in the inguinal canal. That's the most common location.
Yes. All right, good.
Can
you tell me, yes, how would you differentiate that from ectopic testis?
Okay, ectopic testis, undescended testis is located along the line of natural descent of the testis, while an ectopic testis is located outside this line of descent.
And
the ectopic testis could
be?
Can I go on, ma?
Yes, could be fully developed.
Testis could be located at the roots of the. Yes, the undescended testis could be atrophic, while an ectopic testis is well developed.
Yes.
Then
and
the ipsilateral, the scrotum, the hemiscrotum of the undescended testis is usually hypoplastic or atrophic, whereas that
Yes.
was with ectopic testis is well developed.
All right. What type of hernia, inguinal hernia, is more common when patients present with ectopic testis? Yes?
Indirect inguinal hernia.
No, it's not
Indirect
associated.
inguinal hernia.
No, it's not associated with indirect inguinal hernia, direct. What should be the treatment for ectopic testis?
Ectopic testis should have an OSCE.
Basically, you'll operate. Okay, what are the complications that can occur in case of ectopic testis?
An ectopic testis is prone to trauma. It's
Yes,
prone to
very good. What about undescended testis?
torsion. It's
What
prone
are the-
to formation.
Yes, what are the complications that can occur when there is undescended testis?
The testis, yes, it's prone to torsion of the testis. It's prone to trauma of the testis. Then it's also prone to malignant transformation.
Malignancy. Okay. Can you please tell me the etiology of testicular carcinoma? Etiology, the causes?
It arises from carcinoma in situ, which is a pre-malignant lesion called the intraluminal carcinoma in situ.
It could be congenital, it could be hereditary. So if you can tell me more.
Okay, but the risk factors could be congenital or acquired. The congenital risk factors are undescended testis. It could also be as a result of a gonadal dysgenesis, Klinefelter syndrome. Then the acquired ones are human immunodeficiency virus infection is a risk factor. Infertility is a risk factor. Maternal exposure to estrogen diet, still testosterone has been implicated. And also patients with disorder of sexual differentiation or intersex, it's also a risk factor. Family history of undescended testis is a risk factor.
There is another that you can maybe tell me, cryptorchism. What, if you can define and tell me what is it?
Cryptorchism or undescended testis is a partial or complete failure of a tesla descent into the scrotum from the posterior abdominal wall.
Yes. And it is associated with what?
It is associated with an increased risk of
testicular dysfunction first, then leading increasing risk to testicular cancer. What is the etiology behind it? Can you tell me? What are the causes behind it?
I didn't get the question, Ma.
What is the etiology behind cryptorchism?
Okay, the etiology behind it, it's a failure of there are two theories that have been implicated, the hormonal theory and also the mechanical theory. The mechanical theory, it relates to the influence of gubernaculum testis that pulls the testis as the embryo unfolds and as fetus.
Okay, what
then
are
also
the
the hormonal theory,
contributing factors towards it? What leads to it or what contributes to it?
The contributing factors are prematurity, low birth weight.
Yes.
It could also be found in patients with anterior abdominal wall defect like gastroschisis, from belly syndrome. It's also seen in Down syndrome.
All right. What are the complications that you should expect?
There's a risk here, 3 to 5-fold increase in testicular cancer.
Yes.
It also increases the risk of a testicular
risk of infertility, inguinal hernia, and testicular torsion. Okay. You did the surgery on it and you removed it and it turned out to be carcinoma. Then how would you classify it?
Okay, it can be classified
Or how would you stage it? How would you stage the condition?
Into it's based on the TNM staging.
Yes.
T1 is a tumor confined to the testis and the tunica, and also the ipsilateral epididymis. T2 involves the tunica vaginalis. T3 involves the ipsilateral spermatic cord, and the T4 involves the scrotum. Then N can be clinical or pathological. Clinical involves the node is present, retroperitoneal lymph node. This is usually pathological after the retroperitoneal lymph node dissection has been done. Then N1, less than 2 centimeter of the lymph node in their widest diameter. N2, 2 to 5 centimeter in the widest diameter. N3, greater than 5 centimeter in the widest diameter. M0, no metastasis present.
Okay. Are there any tumor markers associated with this carcinoma that you should follow
Yes,
up?
ma'am.
Yes.
Yes, ma'am. Beta human coronary gonadotropin, lactate dehydrogenase, and alpha fetoprotein are commonly added for.
Yes. After you've done surgery, you got the biopsy report confirmed. How are you planning to follow up this patient? What should be the, according to the NICE guidelines, how should you follow up the patient afterwards?
Okay, patients are followed up routinely by regular clinical examination. Then
how regular? How frequent?
Six monthly
for how long?
5 years, and for 5 years, and yearly thereafter.
Okay.
With
yes.
And yearly thereafter, one will do a regular clinical examination vis-a-vis the scrotal examination, abdominal examination, and also radiological examination, scrotal ultrasound, scanning the contralateral testis, abdominal ultrasound. One could also do abdominopelvic CT scan as imaging modality, especially for patients that had retroperitoneal lymph node dissection.
All right. Okay. If the age of this patient, since this is a young patient, 35 is not old enough, well has gone, but still I want to know if the age of the patient was double, like he was 60 plus, and had the same symptoms, and biopsy showed that it was testicular carcinoma, what might be the cause in that case?
Likely lymphoma.
Yes,
in that age.
Good.
Not
Very good.
lymphoma.
That's because of the age. Very good. Good.